Hello, everyone, and thank you for joining us. This is episode 25 of the Akkad and Koka Report. I'm your host, Michel Akkad in San Francisco. My co-host, Anish Koka, is unfortunately unable to be with us today. Our focus on this episode is on medical students. As many in our audience undoubtedly know, U.S. medical schools overwhelmingly support centralization of healthcare and healthcare decision-making. That is not a surprise, since over the decades, academic institutions have greatly benefited from the centralizing effects of healthcare policy. Because centralization of healthcare is detrimental to the doctor-patient relationship, students who begin their training motivated by a genuine desire to practice medicine in a meaningful and personal way can easily fall into disabuse or disillusionment, and can even adopt a cynical attitude toward the medical profession. Our guest today leads an organization that is dedicated to offering medical students an alternative perspective on healthcare and its possibilities. The Benjamin Rush Institute is a nonprofit organization that embraces the supremacy of the doctor-patient relationship and the importance of free choice and free decisions in healthcare. The organization aims to make students aware of non-bureaucratic alternatives to medical practice, to educate them about the real forces at play in healthcare economics, and to put them in touch with physicians and institutions that have successfully escaped from the morass of the healthcare system. Beth Haynes is the medical director of the Benjamin Rush Institute. She is a graduate from the University of Cincinnati School of Medicine, and she practiced emergency medicine in a private setting before focusing her career on healthcare policy and advocacy. Over the years, she has been involved in the leadership of a number of organizations aimed at improving medical care in our country, including Docs for Patient Care, Doc Squads, and the Black Ribbon Project, which she founded in 2011. She is a frequent speaker and op-ed writer, and I'm delighted to have her with us to tell us about the Benjamin Rush Institute, which can be found at benjaminrushinstitute.org. Beth, welcome to the show.
Thank you, Michelle. I'm so glad to be here. It's, as you know, the future of medicine is really going to lay with the medical students, and it's just absolutely crucial that not everybody's going to agree with a free enterprise, limited government focus as far as the solutions to all the healthcare challenges that we face. But at the very least, the students need to be exposed to those ideas. And currently, what little health policy education they get, and it might be about 14 hours on average over the 4-year medical school education, most of it is really from a central planning, government is the solution perspective. And it's unusual for the students to get exposed to any ideas that are contrary to that focus.
I couldn't agree more. So, tell us about the BRI. I'm sure you have an elevator pitch about what BRI is and what it does, and how it plans to go about, changing people's minds, or at least exposing students to this different perspective.
Yeah, so Benjamin Rush Institute is now about 7 years old, and we partner with medical students to help them set up chapters on their campuses and then provide support to them for bringing in speakers, holding debates, any kind of events that really are on any topic that the student's interested in that really isn't covered in their traditional curriculum. Things like medical ethics, healthcare policy, the business aspects of medicine, some of the innovative free market alternatives that are currently working. They're up and running, and their successes, and the students need to know about them. So that's basically what we do. Just partner with the medical students, try and figure out what area that they are particularly interested in, and then we have a bank of resources, speakers bureau, and some funding to help them be able to set up these events so that they can then share these different ideas with their colleagues and their professors.
Good, and I'm glad you put all these topics together: medical ethics and business structures and whatnot, because they're all related.
Absolutely.
Otherwise, in medical school, I remember you have your ethics class, and it's completely independent from anything that has to do with the practical aspects of medicine. But the two are completely intertwined, and to separate them is false and flawed.
Oh, one of my favorite subjects to discuss with the students, and I've gone from a point of view of like lecturing into a style where I'm really trying to facilitate an inquiry with the students. And one of the topics is healthcare a right? Because it's such a good, feel-good statement. But if you don't think about what does that actually look like when you try and implement that through policies, particularly from top-down laws, regulations, what does that look like? What's the practical picture? What occurs? What do you need to do? Is that really the way we want to incentivize people? Is that the kind of relationship we want with our patients and with our colleagues? So,
right. Very good. So give me a broad overview. How many chapters and how many medical schools, that sort of thing?
Yeah, well, over the years, we've been on probably close to 40 or 50 schools, but it's one of our challenges is really keeping the continuity, because we get them really only for 2 years. Once the students get into the clinical years, they're just way too busy to be involved with this kind of stuff. So right now we have somewhere around 25. We've got 5 in development. We have a couple international chapters as well. We have one from Nigeria and one at Sackler University in Tel Aviv. And we're toying around with some other things that, I'll wait to see that it comes through before we make a claim on it. But it's mostly we are interested in participating in the United States, and not just with medical students. We've also had a chapter that was a dental school. I've had one that was podiatry in the past, pharmacy school. So really the healthcare professional students, all of those groups are touched by the healthcare policies.
Okay, very good. And is it by word of mouth so far that you have your growth? I mean, people just hear about it, the students will hear about it, will tell another student in another medical school and say,
yes,
you have this chapter.
Yes, and it's been tough to get in. Really, the administrations, and I understand this completely, administrations of the universities and colleges of medicine want this to be student-led. So it's a student organization. And so they're not interested in having a bunch of outside people come in and pushing a program. So it really has been word of mouth, and that's what makes it such a challenge.
Sure. Right. It's a challenge. But, the status quo has the advantage that the students are so busy, learning, garbage that they will never use for the most part later on, that there's very little time for them to be able to involve, but it's very hopeful nevertheless. I think it's great that you have these chapters, and to the extent that we can spread the word here on this program, that'll be very good. So you have chapters, and they try to organize an event per year. I mean, I can't imagine a chapter doing more than that. Or
we try and our most active chapters might have 3 events a semester.
Oh, wow. Okay.
And maybe one major event, like a debate that involves, or a panel discussion that involves more than just one speaker. But our active chapter, and we've had film screenings, and they do charity events. There's a wide variety of things that they do. But the active chapters, probably 2 to 3. I think the busiest chapter one year had 5 in a semester.
All right.
But, and again, because we have these resources to be able to say, hey, here's people that are local. Here's a little bit of funding to try and bring people in from outside that are more national speakers. And then once a year, we have an annual student leadership conference. And that's our big event, something that you participated in and came to speak to. And every year we have a theme that we look at. So.
Okay, very good. And so it's been 7 years. So you've had students that have graduated from medical school, I suppose?
Yes.
Right.
Not many have gotten through residency, although now we're starting to see some.
Okay.
Yeah.
Okay.
And there's one student from the University of Cincinnati who was very active, and he's actually now working for the Indian Health Service. And he says he never thought he would end up being in the Indian Health Service, but he also attributes his experience and what he learned through Benjamin Rush Institute to being able to be a much better advocate for these patients of his that are stuck in a single payer, centrally controlled system. But he knows what he needs. He just has a better sense of what he wants to do, the importance of really providing for these people, and sort of how to go about being their advocate.
That's very important because even if the system, we can't change the system overnight for sure. So many doctors will continue to work in the system, but understanding the dynamics of the system and how the system can influence things, generally I think in a negative way, but regardless, I mean, understanding the dynamics and what how planning and centralized billing and subsidies and so forth affect decision making, for doctors and for patients as well, is very important. So I can see why one would benefit from being exposed to the ideas, even if they end up working, in a large
institution, whether it's a
Correct.
government institution or a large hospital. Yes, they'll go in there with their eyes open. Very, very important. And part of the challenge too has been not everybody. The best opportunity right now in the free market that is just out there waiting and lots of resources is the direct primary care movement. And of the leaders that we've had, not everybody, only a small portion of people go into primary care, but we're seeing more of that. So now I have a number of former student leaders that are in their family practice residencies, specifically with the purpose of wanting to, as soon as they get out, open up a direct primary care. And I have another student who is a fourth-year student this year who we learned about through the Free Market Medical Association, and he wants to become a surgeon and eventually open up a ambulatory surgery center like the Oklahoma Surgery Center. And so we're able to supply him. But, as we're getting more free market models in the specialties, I think we're going to see more people be able to implement these ideas in their actual practice.
This is terrific because when I started medical school, I recall vividly that I wanted to be a generalist. I wanted to go into primary care. And I think many students start off like that. At least their first impulse, and then when you go through medical, through your training, whether it's in medical school, then you realize that in the system, the generalist is really put at the bottom of the totem pole, the pecking order, and it's really a very thankless job in the system to be a primary care physician, and therefore people who otherwise would do general care, primary care, end up choosing to subspecialize so that they at least feel that they can have a little bit more control and a little bit more margin of maneuver compared to the primary care physician. But now the direct primary care movement, and we haven't yet had a we had Keith Smith talk about the Surgery Center of Oklahoma on the show, and I'm sure we'll have a direct primary care doctor talk about this. But the direct primary care movement is so hopeful, and to me, I call it the revenge of the generalists. Because the ones that are doing this and are successful at it, and it's not simple. I mean, it requires a lot of thoughtfulness and resourcefulness and so forth. But the primary care physicians who are successful at it are extremely happy and extremely independent, and they're really in the best possible situation because they practice the way they want. They're not. They feel autonomous. They're not under the thumb of a bureaucracy telling them what to do.
And their relationship with the patient is what you always dreamed of when you go into medicine.
Correct. Exactly right. So
it's great. It's yes, we want these business models to be successive, and you want to be able to get a return on your investment of all those years of training and delaying being in developing your career directly and all that stuff. But without that doctor-patient relationship that we all dream and long for, it's a soul-sucking job.
Absolutely, and so I think that if people are aware, students are aware at that stage, I mean, it has to be at the stage of being a medical student early on.
Yes.
If they're aware of this pathway of direct primary care and being independent, having meaningful relationships with your patients, and then some of them are very resourceful and do a lot of office procedures. I mean, so they use the whole gamut of what family medicine is about, which otherwise in big box medicine they end up losing, some of the skills that they learn in their family practice training. So they keep those skills, of procedural skills, and do this, and I think it will attract. I imagine I think that this heavy specialization is not primarily driven by technology. I mean, there's some of that, but it's driven by the system, as I was mentioning, that favors specialists, and that's why there's a dearth of primary care doctors, and students are not choosing primary care.
Well, it's not just that. Yes, we've got a system that CMS set up with their administrative pricing that has been favoring the procedurists for a long, long time. This is no mystery if you really look at what the incentives are, and it's not the free market. It was CMS putting in what their whole relative-based value system and giving the weight to all the specialists. But on top of that, all of our education, almost all of medical school education, is being done in academic centers.
That's right. But that's also, I'm glad you make that point. I'm sorry, go ahead.
Yeah, I just want to say, because I went in wanting to become a family doc, and I did train as family practice. Once I got out, I did it 1 year, and then we moved, and I was moonlighting, and found out I'm actually more of an adrenaline junkie than I realized, and I wanted to stay with the ER. But when I told my professors from medical school that I wanted to go into family practice, their response was, "Oh, Beth, you're much too smart to do that. Don't waste your time." Right. And I'm surprised that even with all the lip service that's being given to the importance of primary care, the students are still being told that by their academic instructors.
I agree. So there's this bias in academic institutions against general care and family practice, and that, as you're right, it predates CMS, if you will. It predates all of that, because if you learn about the history of licensing and licensing laws,
yes.
The main benefactors of the Flexner reforms have been the academic institutions.
Yes,
it was part of the same sort of movement. So you're right, absolutely right about that. There's this cultural bias against general practice. Which is really unfortunate. It's really the heart of medicine is a long-term relationship, which is best exemplified in primary care.
And I am reading some things about where was this interview that I heard where they're talking? Oh, it was someplace in Connecticut. And if you guys have notes, I can get you the
show
reference to that podcast.
Well, definitely.
Show notes. But there was a hospital administrator. It's a community hospital in Connecticut, and they have a residency program, and they are going to be training people who are clinic-based and doing it in a way that this whole primary care thing is the absolute emphasis rather than the procedural. And just a couple other things that this hospital system has done has been way ahead of its time in support of getting away from sick care as opposed to wellness care and preventive medicine and that kind of stuff. So anyway, I'll send you that. The other thing that's really fascinating was a PA student that we partnered with a couple years ago worked with us and did surveys, and he published that, and I can get you the reference for the paper that he published. When medical students, they did a survey before and after hearing a lecture where a direct primary care doctor spoke. What was their interest in primary care? And it went way up. So once these students learn of this model, their interest in primary care goes way up. So it's just, it's a fascinating time. I think it's just really great. And I listened to another podcast. Actually, it was on the Benjamin Rush Institute podcast, was recently interviewing a gentleman who is a business supporter for direct primary care, and he is helping an orthopedist start a direct pay practice.
Okay.
So we kind of have the model.
Right.
We have the model for the primary care. Now, how are we going to include the specialists in the system where there is that direct, and it's not going to be a membership base most likely, but it will be direct pay, That's
right. And in a way, that's what my practice is about, because I do practice internal medicine, so I have a membership-based direct primary care model practice, but I also have my outpatient cardiology practice, which is direct fee-for-service, because it lends itself more. So again, you have, there's not a model that's going to fit everything, but you need to have the freedom, right, to decide exactly how you're going to design your practice and so as to offer the best services for the patients.
And fee-for-service has gotten such a bad reputation because people think of it as fee-for-service within the third-party system, and that doesn't work, and that will drive volume, not value. But the rest of our economy is based on fee-for-service, and there's not been that problem. So when you have that direct economic connection, and I'm just telling you what you know, but for the listeners, that direct economic connection between the doctor and the patient, where those two people are aware of the cost and really make those cost-benefit decisions truthfully based on the best information that's available to them as a unit working together as a team, then you don't get the whole
of course
volume push that you get within the third party system, where the people who make the decisions are the least knowledgeable about the actual costs.
Of course. I mean, let's take as an example my cardiology practice, right? I can't just, it's not so easy for me to convince people to have echoes, all the time or something like that if they're going to have to pay for it out of pocket.
Right.
There has to be a justification. They need, to recognize themselves and experience the value of it. And
well, you don't get the reputation as being a reputable, worthwhile, valuable advisor if you don't keep the patient's best interest primary, because that's what you're being paid for, right?
Right.
So it's, people see it as a conflict of interest, but absolutely not. The way I will thrive as a fee-for-service direct pay physician is if I offer the best value for the dollars that my patients are spending.
Of course, because either you want to retain the patients or you want your reputation to spread.
Yes.
Right. And
absolutely.
none of that will happen if you're greedy.
No.
Greedy, that's not going to happen, right? We had an episode not too long ago where I just made that point. Greed has no economic value on the free market, right? It's so that's very good. Let's go back to the BRI. I was at the history of it, and you're following a model that had been applied in law schools, right? I mean, so there's
correct.
Can you tell me a little bit about that?
Yeah, so there's a number of student campus-based organizations that have followed the model that was started 35 years ago by the Federalist Society.
Okay.
And there was some law students who were just amazed there wasn't any presentation through their curriculum of like original intent or reading the law as plain language.
This is all sort of a constitutional theory.
The constitutional theories. It was all this living constitution. And so they wanted to bring in this alternative point of view. And at the time, it was really actually ridiculed among the legal academicians, just the way free market is vilified or ridiculed currently in medical academics. So they started this just as a local chapter, and then it spread. So Sally Pipes, who was the founder of the Benjamin Rush Institute, saw a need for this right around the time when the debates of the Affordable Care Act. And she said, we need to have medical students understand the free market principles, economics, at least hear a dissenting voice on campus. And she used the Federalist Society model to do that. And then there's also a similar thing for foreign policy. There's one for MBA students. So it's a model that's being used.
Right, I understand. And I think it's terrific. I mean, that's all we want, really. All we want is a chance to have this message be heard, because I believe that it's a very compelling message, and so once students are exposed to it, they will. I mean, not all of them, as you said, but many of them will start to think differently, and then make their own contributions, because they're living their own career, and this, the importance of freedom for innovation, for dynamism, for to help the patient is so underestimated, right? It is so underestimated, because we only tend to pay attention to the way things are, right? And neglect the fact that with imagination and with freedom of movement, you can make things better.
Nobody benefits from existing in an echo chamber. We don't.
Right.
With whatever point of view we have, and neither do people whose point of view differs from us. And the way we're going to come to the absolute best solution that we can as imperfect human beings is to really get in there and share ideas. I mean, I learn so much more from people who disagree with me than from people who agree with me. Keeps my thinking sharp, keeps me more honest about what I know and what I don't know. And so we need to really break into that echo chamber, to everybody's benefit. And it doesn't mean that, we're going to convince people of our ideas, but maybe we can show, hey, have you taken into consideration this really potent negative and unintended consequence of your policy?
Yes, right, exactly. So what's on the horizon for the BRI for this year or next? When is the conference? Is it in the winter?
This year is so as we've been growing, we've been able to add more and more of. Initially, it was like a day and a half, and then more recently, we've had 2.5 days with a policy day as well as sort of chapter training. This coming year, we're going to partnership with the Free Market Medical Association, so that our policy day will actually be the Free Market Medical Association conference.
I see.
And then, so we're going to be in Dallas in April. And then our chapter training and some things that are more specific to the medical students will be the day following the Free Market Medical Association annual conference. So I'm super excited about that. Again, because there's so many, that it won't be just direct primary care. It's easy to get direct primary care people. I feel like we've really educated our group of students on that. And that next stage of solving the problem is all those other areas of medicine that I think the Free Market Medical Association is really coming up with amazing creative answers to.
I agree. That's terrific. And there's a question I meant to ask you earlier, but I'll ask it now. Do you have faculty who have expressed an interest in the BRI and who could? I know that
there's a few. Yeah, they are far and few between.
Right. I imagine, but I think it's important to put it out there. I think in the audience of this show, there are several academic physicians.
Oh, we would love them.
And so I think it's if there's a faculty member here who's in a medical school who's sympathetic to free market ideas, or at least sympathetic to the idea of
the conversation,
right? So some pluralism here, having the
yes,
then they can mention this to some students and get the ball rolling. To have a chapter.
The other thing, Michelle, that is that we will do is if there isn't a strong enough interest in the students to actually form a chapter, we are more than willing to partner with the student sections of the AMA or with AMSA to hold an event that, again, shows a variety of viewpoints. We've been invited to supply the free market point of view a number of times at Einstein by the Students for a National Health Plan. And it's been a fabulous partnership.
Very good. Very good.
I've learned a lot. I think they've learned a lot. And so it doesn't have to be somebody who's dedicated to free markets. And there's been, I think the majority of our faculty members have been those who just say, well, I'm not sure that, this is my cup of tea or point of view, but I want to support the students who want to have that broader conversation occur. So yeah, both in chapter formation and just holding events.
Right. Well, that's terrific, Beth. I'm really very happy for this the work that you're doing and the organization is doing, because as you said, it cannot be just doctors in practice, carving their niches and so forth. We have to talk to the students and let them know from the get-go. So that's very important. That's really the future of medicine, as you said. And can you tell us again where to find the BRI online?
Sure. So our website is benjaminrushинstitute.org. And the other exciting thing that we started about a year ago is we now have a podcast called Next Generation Medicine, the podcast by medical students for medical students.
Very good.
And I know you've been one of our guests on that, but we have a wide variety of people that have been interviewed. David Goldhill, we've got Tulsi Ravilla, who is the executive director of the Aravind Eye Care in India, and Keith Smith. We've got a number of direct primary care, wide variety of people that have been interviewed on that, and that's available on iTunes. You can also access it through the website.
That's great. I'm glad you mentioned that. It's a terrific podcast. And I'll tell you, the medical students who interviewed me, I've been interviewed on several podcasts over the last 2-3 years, and it was the best interview I've had. He keyed on the asking the right questions, and it was great. So I'll put a link to the podcast as well as the organization, and I really encourage students and everybody else to listen to it.
And if they have any ideas of who they want us to interview, to send us suggestions, because we're always looking for that too.
Sounds great, Beth. Anything else?
Oh my gosh. Mostly just try and spread the word. Again, we want to be a platform for broad conversations and really crowdsourcing these solutions. That's really what the free market point of view is all about, is crowdsourcing information and trying to be creative and support the innovation that we need. Then we have real challenges, and the challenges include how do we care for our most vulnerable students, our most vulnerable patients, the poor and the really sick. And I think that the free market has a lot to offer specifically about those populations, as well as how to really support and nurture that physician-patient relationship, which is a crucial part of the healing.
Amen.
For both of us, right? For both
Absolutely.
parties. Yeah.
Very good, Beth. Thank you very much for being on the show. And,
okay, thank you.
I look forward to staying in touch with you.
Great.